I realized, I've been to a lot of in-person presentations, but this is the first one I've done in person since before the pandemic, so might be a little rusty. I even had to make sure I actually was wearing pants. So I'd like to thank the Society of Mechanical Ventilation for inviting me to speak to you about airway support on the smaller patients. And even though this conference is about mechanical ventilation, I'll also briefly go over heated, humidified, high-flow nasal cannula therapy, or high flow for short, and how that's being applied to the pediatric population. As a disclosure, but of no financial benefit to me, I'm the site PI for this multi-centered international study based at Children's Hospital of Philadelphia on pediatric ARDS that I'll describe in more detail this half hour. And as I mentioned earlier, I'll go over the application of high flow in infants and children, and then dive into mechanical ventilation management in children with ARDS, which will include describing this prospect study on pediatric ARDS management. And as a quick review on the mechanism of high flow, current prevailing theory and consensus is that it washes out CO2 from dead space. And the hope or goal is to facilitate and even enhance CO2 clearance, which may then lessen the patient's drive to hyperventilate in many lung diseases. And it's nice that it's a simple setup, and unlike BiPAP, for example, it doesn't require a tight seal. And so it's more comfortable, but it's still irritating to infants and children because of the higher flow rates, and we typically need to sedate them. Now, this past winter season hit us pretty hard for respiratory infections, harder than past seasons, and not just with RSV, but also human metapneumovirus, adenovirus, and in particular, the flu. And for infants up to about 2 years of age, bronchiolitis and RSV in particular can cause two types of problems. One, it can cause severe wheezing and air trapping similar to asthma. And two, it can cause parenchymal lung disease or pneumonia, which then decreases the lung compliance. Now, for patients presenting in severe respiratory distress, we typically try high flow first, mainly because of the fast setup and ease of use. But sometimes these patients require more than just CO2 clearance and respond better to positive pressure. And how much flow would you really need to have to actually make a difference on worker breathing? A few studies from Children's LA looked at varying flow rates and impact on worker breathing in the form of pressure rate product, which is the product of the change in esophageal pressures as a substitute for pleural pressures and respiratory rate. In a 2014 study, they demonstrated improved worker breathing with higher absolute flow rates as seen with lower pressure rate product values. But this was not associated with increased PEEP, where esophageal pressures didn't change with higher flow rates. In Children's LA later in 2017 here, actually right here, was able to reproduce their results of lower pressure rate product values with higher flow rates, but also demonstrated a weight-based effect to flow rates and worker breathing rather than absolute flow rates, as seen here on this diagram. For smaller patients, less than 8 kilos, the drop in the pressure rate product decreased significantly with increased flow rates. But those who are larger than 8 kilos, their pressure rate product didn't decrease to a statistical significance with those same flow rates. And again, even later with from Children's LA, they compared worker breathing with electrical impedance tomography and esophageal pressure in the same less than 3-year-old age group. And again, demonstrated a drop in pressure rate product and worker breathing, but no change in lung volume or PEEP, and which suggested that it wasn't positive pressure that was the primary mechanism of high flow. And here's a typical chest X-ray on a toddler we recently had with bronchiolitis. And let's see what kind of effects high flow had on his respiratory distress. This is a graph comparing respiratory rate and flow rates from the high flow device. And in the beginning, he was fairly tachypnic at the start. And as the flow rate increased to this point, which was 18 liters per minute, or for him, 1.5 liters per kilo per minute, you can see that his respiratory rate, oh, actually, the pointer is not on. I've been using a pointer here all this time, but I just looked up. Let's see if I can actually pull up a pointer. Oh, there I am. Okay. So he was pretty tachypnic in the beginning. And as we increased that flow rate up to this point, which was 18 liters per minute, and again, for him, it was about 1.5 liters per kilo per minute, you can see that his respiratory rate dropped to almost 50% and stayed there. And that basically gave him time for recovery or resolution of his lung disease, and at which point then we could wean his high flow off. Now this patient is a bit sicker, and this looks like bad ARDS. And as a review on ARDS criteria, the most recent guidelines for pediatric ARDS was released in 2023. And one of the more notable changes from the earlier Berlin definition of ARDS to a pediatric specific definition of ARDS in 2014 was the change from PF ratios to oxygenation index for defining the severity class. And this includes the use of oxygen saturation index as a substitute if there were no arterial samples available. And those on non-invasive support were also included for ARDS evaluation. Radiographically, the requirement for new infiltrates was no longer limited to bilateral changes. And then with this most recent update, they also included patients on high flow. And this is a graphic from the 2023 consensus work group in pediatric ARDS with their recommended approach towards management. I'll break down some of these management strategies in the next few slides. And again, this is the ARDSnet trial that you may be familiar with on adults comparing 6 to 12 milliliters per kilo and showing a difference in mortality rate outcomes. And since that study, pediatric ICUs have generally targeted volumes in the middle around 8 milliliters per kilo and then titrate accordingly. And by titrating accordingly, I mean that we try to ensure that peak inspiratory pressures remain 28 centimeters of water or lower, or up to a max of 32 centimeters of water for moderate to severe ARDS. At some point, though, we may switch over to pressure control or pressure limited SIMV when peak inspiratory pressures begin to exceed that max of 32 centimeters of water. And in conjunction with limiting peak inspiratory pressures is the targeting of lower O2 saturations. For milder ARDS, maintaining O2 saturations in this 92 to 97% range isn't really that difficult with fairly reasonable mechanical vent settings, and FiO2 is less than 60%. The greater challenges are with the more severe ARDS patients, where we try to keep FiO2 60% or less and limit peak inspiratory pressures. And by targeting O2 saturations between 88 to 92%, hopefully we don't have to beat up those lungs so much. And as we try to limit barotrauma and volley trauma by primarily using PEEP to improve oxygenation. And I'm not going to go into any detail about PEEP management here, but I wanted to show you this picture of my friend's Keep the PEEP t-shirt. And the other sort of last-ditch effort option that we use for refractory ARDS is the oscillator, or high-frequency oscillatory ventilation, despite the fact that there are several trials that have failed to show any improved outcomes so far. But for these patients, it's either that or ECMO. And I won't go over APRV since that was very nicely covered, not only before me, but also yesterday. And we don't really use that in our PICU, but every now and then we do try. I think mainly it's because we're not as familiar with it. But you know, the comment that Dr. Downs made on ECMO patients and resting lungs, I totally agree. And hopefully at some point we are moving away from that culture of just letting it completely collapse to actually keeping it open. And on the flip side of oxygenation is ventilation, which I'm sure you're all familiar with, permissive hypercapnia, again, brought up before me. And generally, we target pH over PCO2, and pHs down to as low as 7.5 for more severe ARDS are acceptable. Or, as Dr. Downs put it, there's nothing we can do about it. And for non-mechanical vent strategies for pediatric ARDS, one of them is the use of inhaled nitric oxide, which we've been using more and more in recent years. In this context, INO diffuses across the alveolar capillary membrane and induces pulmonary vasodilatation in lung segments that may not have had adequate blood flow. Now, hopefully, the redistribution of blood flow in open but underperfused alveoli increases O2 absorption and thus improves oxygenation. Now, this isn't a universal recommendation for pediatric ARDS, but it is an option on a case-by-case basis. And you may have actually seen a dramatic response with INO during the pandemic in your SARS patients. As you may know, children didn't really get SARS, but we did have 2 large teenagers with bad SARS from COVID-19, one intubated and one that we managed to maintain on high flow, mainly because none of us wanted to intubate this massive man-child who was over 160 kilos. We put both of them on INO, and their change in oxygenation was like night and day, which for our 160 plus kilo patient on high flow, that was his saving grace. Another non-ventilator strategy is systemic steroids. You all may recognize this, the Maduri protocol. Since it's not routinely recommended for pediatric ARDS, we're about 50-50 in using it, and so far, and more so for our older patients. And last but not least, we use prone positioning as an option for improving oxygenation, especially when the patient's struggling. And you also should recognize this diagram of the West zones from pulmonary physiology in med school. And proning isn't a new concept. And there's some nice studies demonstrating the benefits with proning, at least radiographically. For a patient with ARDS to lie supine for an extended period of time, there's a high likelihood that the dependent lung fields will become consolidated, which is a zone 3 physiology, as you saw in the previous slide, where there's very good perfusion, but very little alveolar inflation. In the non-dependent lung field, there's great aeration, but poor perfusion due to high inflating pressures, which is zone 1. And here in the middle are lung segments with better VQ matching, or zone 2, which is what we want more of. And by flipping them, all that concretion begins to move towards the anterior lung fields, which are now the dependent lung fields. And as that occurs, alveoli open up, and for some period of time, they become zone 2. In the meantime, the lung segments in the anterior lung fields that were hyperinflated but with no perfusion now are less hyperinflated, and blood flow returns to these lung segments here, which is again zone 2. For pediatric patients, an attempt to study this was made about 15 years ago to see if prone positioning was beneficial for those with ARDS. But the study failed to demonstrate any significance. But anecdotally, we often see improved oxygenation. Which brings us to the PROSPECT study, or the Prone and Oscillation Pediatric Clinical Trial. The PROSPECT study aims to definitively see if prone positioning or the oscillator are beneficial in pediatric ARDS. It's a prospective, randomized, 2x2 factorial, multi-centered, and international study based at Children's Hospital of Philadelphia and was started in August 2019. One possible mistake in the methodology of the first prone study may have been that they included those with mild ARDS. This study, however, includes only those with established moderate to severe ARDS. The primary goal is to see if prone positioning or the use of the oscillator have any benefit in ventilation-free days or ventilator-free days. Eligible patients are children up to 20 years of age who have met the criteria for moderate to severe ARDS. There are currently over 50 participating centers around the world, as shown on this map, and we joined the study in October of 2020. The original enrollment was actually 1,000 patients. However, ironically or paradoxically, the pandemic almost killed the study because children were all of a sudden not getting sick, which meant very few were going into ARDS. Why weren't kids getting sick all of a sudden? Because they were being sheltered at home, not playing with other kids, not catching colds or any other communicable diseases. And unfortunately, although not for the patients, they started going back to in-person schools, daycare, and started getting sick again. And the ARDS cases started to pick up. But because of the pandemic setback, the enrollment goal was decreased to 800. And currently, we're almost at 400. And for our relatively small center, we've enrolled 13 patients so far. And regarding management, the goal is to find the optimal PEEP. And the procedural steps are shown here on this slide here. And these are for the randomized, those who are randomized to conventional ventilation. And basically, PEEP is increased slowly with a pause for equilibration. And as long as the O2 saturation increases, PEEP continues to be increased until the O2 saturation either doesn't change or begins to fall. That PEEP is then designated PEEP hyperinflation. PEEP is then decreased slowly and stepwise until the O2 saturation falls to more than 2% from the highest O2 sat obtained during the upswing. Once the O2 sat falls that low, the stepwise decrease of PEEP stops, And that low PEEP is then designated PEEP de-recruitment. And after that, PEEP is increased back to PEEP hyperinflation or PEEP max for 2 minutes, and then set at 2 centimeters of water above PEEP de-recruitment, which is then the optimal PEEP. And for those randomized to the oscillator, instead of changing PEEP, the mean airway pressure is increased and decreased in a similar way. Once optimal PEEP is found for conventional ventilation, the ventilator settings are adjusted according to this PEEP FiO2 titration grid to keep O2 saturations in the target range. And for those on the oscillator, mean airway pressure is titrated depending on if the FiO2 is able to be weaned down below 70% or not. Now, these two patients must have heard that I was giving this presentation because they conveniently and fairly recently were admitted to our PICU almost back to back with severe ARDS. Both were about the same age and both had pneumonia as the etiology. And the one on the left did not consent to the study, and the one on the right did. The one on the right that was consented was randomized to the prone conventional ventilation arm, while the one on the left remained supine on conventional ventilation. So basically, I did a controlled prospective study with an N of 2. And for study patients randomized to prone positioning, they remained prone for at least 16 hours a day. In the following slides, you'll see their chest x-rays side by side as each day passes, and you can see how they progressed until extubation. And this is day 1, the day they were intubated. And with an OI score much greater than 16, they both had severe ARDS. And this is day 2. I didn't include any ventilator or OI data for these intervals, but you can grossly see the kind of state that they were in. On day 3, the study patient on the right got 2 pigtail chest tubes placed, one on each side, that drained quite a bit of transudative fluid. The pleural cultures, though, did not grow anything out. And this is day 4. Both continued to have moderate to severe ARDS. And for study patients randomized to prone positioning, we stop proning once the OI falls to less than 8 or an OSI less than 7.5. And this is day 5. And honestly, I wasn't so optimistic about the study patient's progress, but his OI dropped down low enough for him to graduate from being prone anymore. And at that point, neuromuscular blockade was stopped. And as a side note, we generally paralyze patients who are prone, especially for infants and children, because they're basically unpredictable, and the risk of accidental extubation in that situation is too high. And this is day 6. The study patient's x-ray appears to be clearing up fairly dramatically. The left one, not so much. And as you can see on day 7, there's no longer an ET tube in the study patient on the right. Meanwhile, the chest x-ray for the non-study patient was looking awful, if not worse than before. The OI was still very high, and the patient was not doing really well. Now, I happened to be on call that night, and basically I was very frustrated that she hadn't been prone yet. And so I told the parent, even though they're not on the study, we do prone patients as an option if we feel that that might help. And so I'm going to flip your child now. Now, next morning on day 8, the x-ray seemed less opacified and the numbers were better. And we essentially kept the patient prone for most of that second day of proning. Flipped the child back to supine in the morning of day 9, then flipped her back to prone later that morning. The chest x-ray continued to improve on day 10, and the OI was low enough to flip the patient back to supine and keep her supine while weaning the vent. And later on day 11, finally got extubated after this x-ray. So I wrote up my NF2 controlled study, and it got accepted into the New England Journal of Medicine. No, I'm just kidding. But in a nutshell, this is the hypothesis for the study with regards to prone positioning. So thanks for your attention, and thanks for giving me the opportunity to share with you some of the things that we do in the PICU at Capuline Medical Center for Women and Children.
Thank you so much, Dr. Feng. Any questions for Dr. Feng? Yes.
I'm just curious, you had mentioned you use an oscillator as more of a last ditch effort, aside from the study. Do you guys at your facility frequency ventilation like the jet or the VDR?
Yeah, the jet usually the NICU uses. We don't typically use it. We just use the oscillator, presumably because we're more comfortable with it. The NICU, they tend to use the jet ventilator more so than oscillator, presumably because they are more comfortable with that. What was the other mode? Yeah, honestly, again, it's more for a familiarity issue, and we don't use that either. And just like APRV, we have used it rarely. When we do use it, at least I feel really happy with the results, but we don't use it consistently.
All right. Thank you so much, sir. We appreciate you being here.
Yeah.
Thank you. I just have a couple of notes. We're going to have 15 minutes break.